This week on the BackTable podcast.
The scale of having thousands of radiologists working in the same organization makes it easy for them to have a lot of data, to have a lot of sites to do their beta training, to do their any research, any clinical or AI research. Any of those just gives enormous amount of data and enormous amount of information, probably the largest in the country. Not probably, it is the largest in the country. As I know, it's like 50 plus million studies a year. So if you combine a few years of work, like you have
that's a lot of data to put in the algorithm.
A lot of data, yes, to work on. And that's why even SIR right now presented several big research projects coming from physicians from Radiology Partners, not just on AI, but on other things like pulmonary embolism, a few other things that came out. Very, very important research, very important data.
I'm your host, Dr. Baheti, coming to you from Tacoma, Washington, where we finally have nice weather. Woohoo! My guest today is Dr. Oleksandra Kutsenko. She's the Chief of Interventional Radiology at Red Rock Radiology Associates. It's a private practice group in Nevada. It is one of the Radiology Partners private equity groups. And that brings us to kind of our topic for today, which is working as an interventional radiologist for a private equity group. Alex, thanks so much for coming on the show.
Thank you, Ali. It's amazing to be on your podcast. Definitely listen in a lot of different episodes, and it's an honor to be here today.
Cool. Well, let's kind of just get started a little bit about your personal career trajectory from when you graduated fellowship to what brought you to your current job.
So I graduated from Miami Cardiac and Vascular Institute, amazing institution, was very happy about my training. After that, decided to find a job where I can explore and gain more skills in everything that I learned in training, which is a little bit of a challenge for someone who is starting out in a career, because in Miami Vascular, I trained all the procedures like vascular work, aortic work, interventional oncology, everything that interventional radiology can possibly include. And to find a job that I would be able to use those skills became kind of a challenge not to lose any of those skills. So initially started my search mostly in academics because I have been involved in quite a few research projects and teaching. So that was my initial take on looking for my future job. And at some point, I realized that if I'm going to academics, most likely I will have to give up either vascular work or aortic work, or I will have to subspecialize in some specific procedures, because most of the academic places are very subdivided, and there's also hierarchy to some extent most of the places. So that kind of led me to explore a little bit more on the private practice side, and explored because Miami Cardiac and Vascular Institute is right now part of the Radiology Partners, also private equity. So I just asked around and told what are the practices around the country, and is there any practice that would suit my skill set?
Did you have any geographic limitations, or were you kind of just open to working anywhere in the country?
I was open to working anywhere in the country. I do prefer bigger cities, so that was kind of my priority, to also stay in a larger urban setting. But otherwise, I was quite open. It was mostly about career choice and my skill set development. Yeah, interviewed in a few places and found this great practice where I'm at right now, doing pretty much all the procedures at the tertiary center, covering 2 largest hospitals in Las Vegas. So doing every procedure I wanted, getting quite great experience here, further building my interventional oncology practice. It was already established here, but I think I'm expanding a little bit more. So I'm very happy right now.
That sounds like a dream job. Sounds like your dream job, which is important,
yes.
Right?
Yes, definitely.
Your story echoes a lot of what I hear from new trainees, existing trainees, and early career folks, which is that they want to practice their full spectrum of what they learned and what they trained in fellowship, right? And in residency now. And it's true because you don't really know what you like until you're a couple years out,
Yeah.
right? Like
Exactly.
you need that time to develop and figure out what you enjoy doing, what patient population you love working with. And so, yeah, being just even having the ability to work and try everything that you want to do it's special. Hard to find, but special. Did you look at any private equity jobs too when you were first coming out?
I did. I did look at just regular private practices, and I looked at a lot of academic places. But as I told, this place, just because of the setting of the hospitals that they work here, it was just perfect fit for me.
Awesome.
And we also have, I did want to do some training, some teaching. And this practice has a radiology residency. So we have 20 residents. So that was another point that was kind of important to me.
Cool. And I see that you're the chief of IR there. You're pretty young. I mean, how long did it take you to get to that position?
Thank you. Yes, I think it's kind of a constellation of different factors. I did take a lot of time during my 1.5 years in the practice to build additional procedures, to build additional oncology practices. I brought several transplant centers, several additional oncological practices, kind of working right now on developing a physician assistant program, and we're starting hopefully in the next month or two. But everything takes time. Brought several additional new procedures, brought several new devices to the hospitals. So I think the more you give to the practice, the more people are interested in bringing you to some leadership positions. And I think it just worked out. So I'm obviously very happy to be in this position and trying to give my best, give everything I can to fit the position.
How big's your section?
We have about 7 IRs right now, and we have total about 30 radiologists total.
What's kind of like your day-to-day like working for RAD Partners? Like, walk me through your typical day.
Most of the days we start about 8 a.m. and we come to work. We review all the cases. And sometimes we have some help either from residents or from nurses, techs. But overall, reviewing all the cases, deciding what comes first because of the acuity of the hospitals that we have. And it's a big tertiary centers. We have a lot of cases on the list, and usually many of those cases are very acute and emergent. And so it takes a lot of triaging. So you bring the most sick patients first and then go with your day. It's also a trauma center and a lot of massive PEs or just PEs, a lot of very acute GI bleeds and all kind of acute problems. So we treat those first. We do have some outpatient patients too scheduled every day. So triaging, doing cases, then finishing usually around 5 p.m. Then the person on call takes over. And so that's most of the days are like this. I do have...
How many rooms do you guys run in a day, and how many IRs do you staff at the hospital?
So most of the time we have about 2 rooms, which is probably it is not enough right now, but we're working on building more. Because one of the hospital is 900 beds, the second hospital is 500 beds. So we have 2 rooms in each, and this is certainly not enough for this amount of patients and hospital beds. But we are working right now on building more rooms in one of the hospitals, in the larger one. So hopefully by the end of the year, maybe we'll have 3 rooms. Sometimes we have to use cardiology, cath labs, or sometimes we use neuro IR rooms. So it's a challenge, but it's to some extent a good challenge because it makes you work faster, you learn efficiency, you learn how to triage correctly. But most of the times we work 1 IR in a hospital, and there is second person who is doing light IR, who's doing CT guided procedures, who's doing biopsies, drains, ultrasound procedures, things like that.
Okay, got it. Okay. And then how about do you read diagnostic between cases? Is there an expectation to do that?
There is to some extent expectation, but it's mostly our practice is RVU based. So everyone kind of decides, and not just decides, but if like your day is lighter, which happens very rarely, then you're probably going to have a little bit less reviews on procedure side. So then but you also have more time to read. So sometimes you do read between the cases. Honestly, most of the times, especially in a larger hospital, most of the time you're just so busy doing cases that you don't have time to read in between. So, but it all depends on the day, and it all depends on probably the hospital. In smaller hospitals, it's a little bit more time usually. But none of the hospitals in our setting is light. So
Yeah, it doesn't
there
sound
is
like
no,
it. Yeah.
yes, there is no like exact expectation that you have to read like, any specific number of CTs or anything like that.
Oh, okay, cool. So it's kind of like read what you can between cases. I see. All right.
Yes.
And then do you have any kind of like scheduled diagnostic shifts, weekend shifts, evening shifts, things like that?
Purely diagnostic, rarely, but we do have that light IR shift that is allow you to read a little bit more because you only do small procedures, and because we have residents, so they do a lot of like paracentesis, thoracentesis. At the beginning of the year, we of course supervise them more. At the end of the year, it's a little bit more relaxed for us because they do more of the work, and then we have more time to read in between. And we also have a shift when we are on call. So we start our call at 3 p.m. So most of the time during that 3 p.m. to 11 p.m., we just do diagnostic, but we are on call for IR. So if there is a procedure after 5 p.m., then we will come in and do procedures. So we don't read, but if we don't have any procedures during that time, then we read till like 11 p.m.
I see. And is that 3 to 11 shift? Is that kind of like a separate shift that you do? Like
Yes, it
kind of like a
is a
night float?
separate.
Like, so it's not like you're there
Mhm.
from 8 a.m. to 11 p.m.
No,
Okay.
no,
Got it.
we never have like, so the person who is working during the morning is never on call overnight. So
Gotcha.
that's one great thing that we have. Very, very
Yeah.
important for quality of life, because we
Oh, yeah.
very, very rarely we are sleep deprived. Because that person will work from 3 p.m. and even if there's case overnight, you still don't need to come into work till 3 p.m. next day.
Yeah, I mean, I love having that night float system. If you have enough bodies, it definitely makes it a lot easier. Getting back to kind of like working in the private equity space, are you heavily involved with the RAD Partners national organization as well?
I did become this year already more involved. I'm right now on IR national board for interventional radiology. So I am more involved with the practice, developing some educational tools, developing some guidelines for our practitioners. It is very interesting because it's a very large organization. Radiology Partners includes 4,000 plus radiologists. It has more than 3,500 sites in the country. We read in all states in the country, and it has probably right now 50 plus million studies and procedures done per year. So it is the largest private equity. So it does give a lot of opportunities to make a difference in larger scale. It's personal. Everyone has to decide for their own how much they want to get involved with larger scale, if they just prefer to go to work and just do the work in the hospital, or if someone wants to do a little bit more work on a larger scale. So I think private equity is great for those individuals who want to do a little bit more.
I'm interested to learn a little bit more about the National IR Advisory Council that RAD Partners has created. Can you give me a little bit of insight into that? Like how many people are on it? How often do you guys meet? What issues do you discuss?
So we have 5 people on the board, and we meet once a month. And we discuss all kind of problems like physician assistant practices. We discuss every meeting. We build at least one educational tool that it's kind of like a short discussion on each disease that we pick. Most recent one was dissection, and we spread that information to both the diagnostic and interventional radiologists. So it also helps diagnostic radiologists to understand what are we looking for in interventional space. So building educational tools, building how to incorporate physician assistants, how to deal with like pre-authorization, so things like that. So it's like I'm still also somewhat new to the to the board. I started, I think, in November. So it's still been like a little bit more than half a year. But it's a very interesting space to see how we can expand our tools, how we can expand our influence. And honestly, I think right now when there is such a huge development, artificial intelligence, and huge development of this tools that will shift diagnostic radiology space a little bit more towards automatization and gives more room for interventional radiology to grow and expand and probably focus on something that artificial intelligence cannot.
Yeah. I think, you mentioned like it's such a gigantic heterogeneous group, right? Like I think RAD Partners is the largest employer of radiologists in the United States now, not private equity or not. They're just the largest employer. And you have really different practices, right? Like you have amazing high-end practices like yours where they're doing everything. And then you got ones, where the hospital can't support that kind of service and it's pretty much just IR light. And I imagine it's very challenging to reconcile the large spectrum of practices that you have and create these overarching tools that will help everybody. Do you mind speaking a little bit more about that, kind of like some of the challenges you face as such a large organization and the heterogeneity of the IRs within that?
Yes, absolutely. I think that is the biggest challenge, but also very rewarding to build this educational tools, for example, because everyone has a little bit different training and teaching something that some of the practices might not be doing, for example, like dissections or aortic work or some kind of advanced peripheral vascular disease, even just from diagnostic perspective of what a vascular surgeon or someone else would want you to tell them from the scan that you're reading. So I think those things, educational is very important. But second is also important to be very flexible and understand different types of practices, understand how to build maybe diagnostic radiologists who will be qualified to do some of the procedures, to expand, because I think in more academic places, diagnostic radiologists mostly just read studies. In private practice and in the smaller rural areas, it is important for diagnostic radiologists to be able to do majority of those light IR procedures. That's what we are training our residents and what we trying to spread the word and to trying to expand this training pattern to many of the training programs in the country, just to expand the capability of diagnostic radiologists in those rural areas. And right now, as you know, there are some practices that like MSK radiologists or abdominal imaging radiologists, they're doing a lot of procedures. They're doing kyphoplasties, they're doing ablations, definitely a lot of people doing biopsies, drainage catheters, lumbar punctures, things like that. So we're trying to expand their capabilities. And it is very important to guide practices the way that their structure is. If it is a large tertiary center, maybe you need to a little bit of more subspecialization. If it is a smaller rural area where there is one or two diagnostic radiologists or one or two IRs only, then they need to be trained in everything and be able to both read diagnostic studies and do some procedures. So it's kind of very, very targeted to specific practices.
Actually, I recently read an article, I just pulled up the stats again, that RAD Partners is involved with 10 residency programs. I didn't know that. And they train over 200 residents a year. So that's not inconsequential. Like RAD Partners is shaping the future of our specialty, whether we like it or not, right? So I think you've definitely mentioned a lot of the positive aspects of working in a private equity group, like all these leadership opportunities, which, by the way, do you feel like you're compensated appropriately for when you do this extra clinical or admin work on top of your clinical load?
For the National IR Board, I'm not being specifically compensated, but I'm happy to be involved. And this is more of my volunteer experience, but to be on a chief of IR and to go on some meetings, some board meetings. We do have tumor board meetings as well for thoracic tumor boards or hepatobiliary, colorectal cancer tumor boards. So those things are compensated additionally to salary and bonuses and everything.
Sure, yeah.
But I can't complain, so I think I think I'm doing all right.
Is there anything that you don't like about working in a private equity group?
I think it is as initially when you start working in a private equity group, you feel like you have very little influence and very little control. Many people might not like it, or some people might not like it. I think the perfect fit for private equity would be two categories of people. One category who just wants to go to work at 8 a.m., leave at 5 p.m., and not think about work ever again until next day. So it is kind of good for people who just go to work as work and leave everything from work at work. So you don't need to think about developing practice. You don't need to think about your billing. You don't need to think about a lot of other things that private equity does give a lot of support with. You do have some money that you're losing as a group to private equity, but at the same time, they give you so much support that it's very easy to be minimally involved in your job. In a minute of like, yes, you do your clinical duties, but then you don't need to think about everything else. You don't need to think about insurances. You don't need to think about contracts with hospitals. You don't need to think about many other things that if you're not a part of private equity, then you would have to think about it. And it would take a lot of your time. So that's one of the group. And second group of people who I think would benefit the most from being part of the private equity is someone who wants to make like national impact, who would want to kind of grow inside the organization and build something bigger. That gives you opportunity to work not just with because most of the practices would be like 5 to 30 people. But if you work on a national level with like private equity, then you influence like thousands of physicians and you influence millions of people. So it's kind of gives you the scale. I think from research standpoint, it's also very good platform for any type of research. Right now, Radiology Partners work a lot with the artificial intelligence and building, from what I know right now, is the most advanced AI program that will be coming out very shortly this year. And it's mostly for diagnostic radiology, but I feel like the more work you can automatize with diagnostic part, the more time you have to focus on your IR skills. At least from IR's perspective, I think it's great. I don't know how it's going to fully impact diagnostic radiologists, but at least from interventional radiology perspective, I think it's a fantastic tool, and I already tried it, and it is truly amazing. And the scale of having thousands of radiologists working in the same organization makes it easy for them to have a lot of data, to have a lot of sites to do their beta training, to do their any research, any clinical or AI research. Any of those just gives enormous amount of data and enormous amount of information, probably the largest in the country. Not probably, it is the largest in the country.
Yeah.
As I said, it's like 50 plus million studies a year. So if you combine a few years of work, like you have,
that's a lot of data to put in the algorithm.
A lot of data, yes, to work on. And that's why even SIR right now presented several big research projects coming from physicians from Radiology Partners, not just on AI, but on other things like pulmonary embolism, a few other things that came out. Very, very important research, very important data.
I mean, I imagine you can, from the IR side with this national group, you can kind of put in some quality metrics or some quality things, things that clinicians always get mad at us about, like filter retrievals, and having good data and a good follow-up for filters. One thing I did want to ask you about is clinic. So, one of the big things about being clinical IR, and you have this big IO practice too, and a PAD practice, is you have to have clinic. Clinic doesn't fit super well into the RAD Partners model, right? It's a loss leader. It's not a revenue generator, but it does create these bigger procedures for you to be able to do and bill in the hospital and keeps the hospital happy. Historically, I've heard, RAD Partners groups around the country where there's a lot of pushback when the IRs want to create a clinic. follow up their patients or even hire a mid-level to be able to help with some of that. What's your experience been at Red Rock?
So I was very lucky to come into the practice that already had a very well-established, 20 years of established clinic.
That's nice. Yeah.
So our clinic worked very well. We did have a little bit of a hiccups this year because our management changed. And that's one of the challenges, I guess, private equity, because when some of the management changes, like local management changes, they might see things a little bit different. So sometimes it is not in your full control of what is happening. But at the same time, from my experience so far, it took about 2 to maybe 3 months to gather all the data, to find all the supporting voices, I guess, to maintain our clinic. So our new management were questioning about if a clinic is actually profitable. So it took a lot of time for us to gather all the information, to gather all the procedures that we generate by having clinic, negotiate with hospitals, some stipend as well. We negotiated a few things, but so far and honestly, they were very responsive, especially even up to CEO. Like I was on several calls with CEO, CFO of Radiology Partners, just discussing my clinic, So it's, on one hand, it's difficult because it's a large scale, but at the same time, even people in the very high positions, they are still responsive and they still find time to discuss important issues with you. So from my perspective, it took a couple of months to justify having clinic, but now we're back in business and our clinic is staying as it was. And I think it is a generator of RVU, first from E&M coding, if you code right. Second, we do smaller procedures like port placement, line placements, paracentesis, all those things inside the clinic. So we do generate those RVUs. And we are trying to read some studies in between seeing patients. Most of the time, we do have time for that. But otherwise, and even so, most of the days in clinic by themselves already generate enough RVUs. Even if they don't fully generate enough RVUs, then on the days they bring big procedures like Y90 radioembolization. We do a lot of those. And our practice did the largest number of Y90s in Nevada this year. So it was
well, congrats. I'm sure you were a big part of that.
Yes. So it was very exciting. And I think the amount of outpatient procedures that do bring a lot of RVUs, they definitely, even if you don't have enough RVUs the day of the clinic itself, the other day when you're doing those procedures that brought you from the clinic, you're definitely compensating to have enough RVUs for both days.
Got it. Yeah. Talking about RVUs too, a lot of IRs in private practice at other groups, when you're paid strictly on RVUs as an IR, it gets very tempting not to be doing longer cases that don't necessarily generate large RVUs for you. Large technical fee for the hospital, sure, but your RVUs are not going to be that high. Do you ever feel a pull to kind of be doing? I think I know the answer to this, but do you ever feel a pull to not be doing as much IR just because you're kind of on the clock as a RVU based radiologist, and it's much easier to just read 10 CAT scans than it is to do a EMBO? Or are you this is part of my job. This is my personality and my identity as an IR. Is that not even an issue for you?
I think it is a misconception that IR procedures do not bring RVUs. I'm actually making significantly higher number of RVUs when I'm doing IR procedures, especially if it's a big procedures. Honestly, right now, doing Y90 treatment takes me 30 minutes. And it significantly, there is no way I can read enough CT scans in 30 minutes to generate as many RVUs as Y90 procedure. So I do think if you do 2-3 big procedures a day, it will give you enough RVUs for the day. And then the rest you just kind of have to do what you have to do for nav tubes and lines
Sure.
and things like that. So it actually more difficult to generate RVUs with smaller procedures. So on those light IR, days, that's when I do need to read some studies to make up for my difference.
Yeah.
But when I'm on actual IR day, we usually have like embos, and like even if embo takes like 2 hours, it's still like 2-3 embos will generate enough reviews. So and we have like thrombectomies and
sure.
I don't know,
Yeah.
we have legs, like, we have peripheral vascular disease work. So all of those procedures actually the highest RVU makers, and we do some endograft placement for aortic work. So those are the highest RVU makers, probably higher. Like if we would be doing a lot more of those procedures, I think we would be making a lot more RVUs than diagnostic radiologist. But obviously, it's not all the hospitals are like that. So we if to think on a larger scale of practices. So in my practice, it's not really a problem to be IR. It's actually a benefit because we do have a lot of those big procedures. If you're in a smaller practice where there is because some practices don't do pulmonary embolism or don't do aortic work or don't do like legs, then it might be a little bit harder to generate those RVUs as IR. But then you also have a little bit more time to read in between. So I think you just choose the practice that fits like your skill set and that fits what you
what
prefer.
Your goals are. Right.
Yeah, and not everyone likes high intensity procedures. Not everyone likes doing aortic work. It's quite high risk procedures, so it's not something that all people do like to do every day.
So from what I'm getting from you, it kind of sounds like the RAD Partners private equity job it's really more like a hospital employed position in that you're an employee. You might eventually become a partner, right? But like, it's not like being a partner in a private practice. You're hospital employed. You kind of get to clock in, clock out if you want. You can be as involved as you want in leadership and in a lot of the committees that they have. And if that's what your goal is, and to not be really super involved with the business side of things, then it sounds like a good fit for you.
Yeah, absolutely. And you can make whatever you want out of it.
Cool. Anything else you want, either trainees, early career folks, or people who are looking for a job change to understand about working in a private equity group?
I think independently, if it's private equity or if it is any type of job, I would recommend to new trainees not to focus on what practice can give to you, and not just to focus how much money you're going to make, how much vacation you have. Focus a little bit more what you can learn and what you can give to the practice, what you can build. And most of the times, leadership of the practices, no matter what type of practice it is, they will notice your involvement and they will notice your contribution. As in my case, like, I did not specifically aim for any positions or anything. I was just trying to build as much as I could and to give to the practice as much as I could. And eventually, you get rewarded for that, either with specific position, like a chief of IR or anything like that, or you will get rewarded financially, or in general, if you work more, you do more procedures, you read more, you get some bonuses. So I think in any job, you first need to give a little bit more, especially in the early stage of your career. And then eventually you're going to get results. It will pay off. Definitely will pay off.
Well, cool. Dr. Kutsenko, thank you so much for being on the show, providing us a little bit of insight into your job, into private equity. I wish you the best because it seems like you're on this amazing career trajectory.
Thank you. Thank you so much. It was a pleasure.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Baheti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.